Hello, and welcome to the DeSera Clinical Education Multi-Specialty Podcast. I'm your host, Jill Frost. Today's episode features three experts who highlight the emerging obesity data from recent conferences that are changing real-world practice today. Dr. Stephano Del Prato is Professor Emeritus of Endocrinology at the University of Pisa in Italy. Dr. Soo Lim is Professor of Medicine, Department of Internal Medicine at the Seoul National University College of Medicine and Seoul National University Bundang Hospital in South Korea. And Dr. Donna H. Ryan is Professor Emerita at Pennington Biomedical Research Center, Louisiana State University in the U.S. They discuss how the latest findings in obesity studies apply to specific patient populations across the U.S., Europe, and Asia, as well as why healthcare professionals should individualize treatment based on patient preferences and relevant risk factors. This episode is part of a larger educational program titled Global Perspectives on Emerging Evidence in Obesity Management: What's New, What's Next, and What Matters for Primary Care. For more information on Drs. Del Prato, Lim, and Ryan, along with a link to the larger education program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
Welcome, everyone. I am Dr. Donna Ryan.
It is a great pleasure to join you and Professor Del Prato. Yeah, I'm Soo Lim.
And Stephano Del Prato.
Thank you very much, Donna. It's also for me a great pleasure to be able to join you here in this discussion. I think that we're going through a revolution now, and we're talking more and more about obesity because, fortunately, we do have now more powerful and more appropriate form of treatment for this condition, including both obesity as a disease by itself and associated type 2 diabetes and all the other comorbidities that often are associated with obesity.
But look, I really want to focus our conversation today around what's been going on in these new developments in obesity. I'm going to ask you both a question. And that question is, what do you think have been the most practice-changing developments in obesity management that have occurred in the last 12 months? I'm going to start with you, Stephano, and then we'll move over to Soo Lim.
Yeah, Donna, I think the major breakthrough is the fact that we are recognizing more and more obesity as a disease, as a condition, that is a disease per se. In the past, obesity was mainly considered the result of misbehaving of people, not diet, not following the diet, not physical activity, and so on and so forth. But we are realizing that that obesity is indeed a disease. Everyone agrees that obesity is a condition per se, and because of that, it requires formal diagnosis processes and formal treatment. For instance, in my country, in Italy, we have now a formal law that defines obesity as a disease, and because of that, there are initial recognition and reimbursement for the treatment of obesity.
What do you think is the most practice-changing development in Korea, Soo Lim?
Yes, I think now it is changing from weight reduction itself to the weight maintenance period. So when you take a look at the attain-maintain study, the patient who had previously received tirzepatide or semaglutide in SURMOUNT 5 was switched to oral orforglipron or placebo. Orforglipron helped maintain a much larger proportion of prior weight reduction than placebo, about 75% after tirzepatide and 79% after semaglutide. So the message is very clear to me. Obesity requires long-term management, and oral therapy may become an important maintenance strategy.
I am so glad you said that. It's a major problem in the United States. We have really good uptake of these medicines, but we really have a problem keeping people on them. These are chronic disease medications and need to be taken over the long term. So I agree. I think the emergence of these oral medications and studies like attain-maintain that show how to transition from an injectable to an oral are going to help with that. I think it's so interesting to talk to my two colleagues from around the world, because I think there's some real differences in the patient populations that we treat. You know, in the United States, I mean, we have really a major problem with severe obesity in terms of very high BMI. Tell us a little bit about the obesity phenotype in Korea and how that impacts your treatment.
That's very relevant to today's topic. So in Asian patients, the East Asian and South Asian both, I'm particularly interested in therapies that reduce visceral fat and active fat because for example, type 2 diabetes, the fatty liver, now known as the metabolic dysfunction steatotic liver disease, or other cardiovascular event, often occurs at lower BMI compared to Western counterpart. Therefore, the real critical question is not only weight reduction, but whether we can reduce the visceral fat or liver fat or the muscular fat and improve insulin resistance and protect beta cell function. We strongly recommend to measure waist circumference in our clinic or sometimes body composition analysis when available. So we try to find the fat excess itself, not just the BMI.
Well, you know, I think that focus on obesity being excess abnormal body fat is something that concept is really worldwide. But Stefano, are there issues that are regional in Europe?
I have to say that by and large, I don't think there is any European country that currently is reimbursing treatment for obesity. While some of the drugs that we've been using for type 2 diabetes are also commonly used also for the treatment of obesity, semaglutide, the high dose, for instance, or tirzepatide, are currently reimbursed for type 2 diabetes. They are not for obesity. But things may be changing. And I think, you know, from a country to country, there are different processes going on. We have been learning more about the obesity. We have been learning more about, you know, what is really the meaning of an excess adipose tissue, and even more to have an excess of a sick adipose tissue, because I think that it's important to make a distinction. So I think that what we probably be learning in the future is to really have a better understanding not only of the obesity as a disease, but also as obesity as a heterogeneous condition, and to have a way to drive and to specifically more indicate treatment for different subgroups of people with obesity.
You know, one thing that I see happening when I attend our professional meetings is that there's always seems to be a symposium about body composition and the effects of weight loss on body composition, on fat mass, and on lean mass.
Yeah.
And this seems to be something that's in the forefront of everyone's mind. So I think it's, you know, I think it all relates to the heterogeneity of obesity and how different our patients are, and how it's really one size does not really define everyone with obesity.
Yeah,
You
exactly.
know, I want to ask you guys what you think about emerging studies. So, what do you think is the most exciting emerging evidence that's coming out, that's already come out in 2026, or that you're anticipating to come out later this year? What do you think, Stefano? You lead off.
Now we're looking for drugs that are becoming more and more effective to the point that we are considering pharmaceutical bariatric surgeries. I would really like to distinguish, you know, what I see of interest in the near future is the injectable and the non-injectable. For the injectable, we have this incredible data, very, very impressive data for retatrutide. So we're moving from a single activator of the GLP-1 receptor to a dual, including the GIP, and now the glucagon, and the triple agonism on these three receptors is associated with a unprecedented body weight reduction. And I think that will be some of the line. Of course, you know, the kind of the drugs that we're going to use may have different indication within the obesity area. Sue already mentioned, for instance, about muscle and muffled, and some of these new drugs are more generated be more specifically directed to the liver rather than the obesity by itself. And also the other thing it's been already mentioned is the oral GLP-1 activators. And I'm wondering when we're going to see the oral dual activators, but also what I think is important is to consider the multiple point of attack on the pathophysiology of obesity. It is glucagon, it is GLP-1, it is GIP, but it can be also amylin receptor activation. We have the recent data from the CagriSema, for instance, also very interesting. It remains also to define or to identify the best strategy to keep the people on treatment. So that's one thing. And the other thing that we need to tackle is that excessive body weight reduction can be associated with a waste or reduction in the lean body mass. But also, I think that we as physicians need also to have a comprehensive approach and remind our people that maybe right now the best way to preserve the lean body mass is to stand up and work out. Because that I think it's also important to keep in mind as well.
Yeah. Excellent. Well, you're talking about retatrutide, and yeah, that was amazing. The presentation at the American Diabetes Association showed that you could have up to 28% weight loss on average with the top dose. That's a lot of weight loss.
Most preservation is very important, as the Del Prato already mentioned. So compared to Western people, many Asians relatively tend to have less muscle mass. So muscle loss with injectable therapy is very critical to those patients, especially elderly population with obesity. So we are now strongly recommend to take high protein diet and the resistance exercise at the very. I'm very much interested in the survodutide. So into the synchronized muscle D, survodutide, which target GLP-1 and glucagon receptor co-agonist, reduced MRI measured fat fraction in the liver. More than 80% of the tide treatment group achieved 30% reduction in liver fat compared to placebo. We are now interested in the organ protective effect of this medication, not just for BMI or weight reduction itself.
Excellent. That's true. So I think we got one vote for retatrutide as being the most exciting discovery of 2026, another vote for survodutide, but I think I'm going to cast my vote for the most exciting thing to happen is the emergence of our first long-acting amylin analog, cagrilintide. It's being co-administered along with semaglutide. And coming behind that molecule, we're seeing those two molecules really. Coming behind that, we're seeing a number of agents that are going to try to capitalize on amylin along with GLP-1 receptor agonism. So that appeals to me for a number of reasons. One reason is that targeting the amylin and calcitonin receptor could have a benefit on body composition. It could have a benefit on bone. And there's even some evidence that it could have a benefit on muscle. The other thing that's really appealing about that molecule to me is the fact that it is insulin sensitizing. Our GLP-1 receptor agonists, they are incretins, but amylin is an insulin sensitizer. And I really like that, especially in early diabetes and in pre-diabetes. So I'm looking forward to seeing more data coming out about cagrilintide and semaglutide together called CagriSema.
I think that's what we need to be in the future is how to going to select these drugs. And I think, I'm a strong believer in individualization of the treatment. So we may also wonder to which extent one drug may be fitting some people and another drug may fitting the need of other individuals. So that will require extensive studies and extensive evaluation, but I think there is a potential there for having multiple ways to attack different mechanisms underlying obesity to provide a more personalized treatment.
I think one of the amazing things that's emerged over the last few years is the fact that our medications not only have effects on weight loss, and they not only improve health mediated through weight loss benefits, but they have effects beyond weight loss. And so we know the cardioprotective effects of these drugs. The GLP-1 receptor agonists also are known to slow the progression of chronic kidney disease. We have effects on obstructive sleep apnea. So these disease-modifying attributes are very, very important. I am really looking forward to the SURMOUNT MMO study reading out in 2027. We all hope this is a class effect, but we really need to demonstrate that with this study.
So,
Yeah, go ahead. Go ahead, Professor Soo.
yes, in the SELECT trial, we found that 20% reduction in 3-point MACE development with semaglutide, 2.4 milligrams. Obesity is a chronic disease, so we can, when we decrease the reduced body weight and especially visceral fat, it should lead to beneficial result in not only cardiovascular but also renal or hepatic outcomes.
We know that, for instance, using semaglutide in the SELECT trial or using tirzepatide in the SURMOUNT-1 trial, it was shown that both semaglutide and tirzepatide can prevent progression toward diabetes in an incredible manner. So I think that we not only have the potential for those people with a high cardiovascular risk or high kidney risk to provide them with the preservation effect or protecting effect of this drug, but also we can start acting earlier and really to prevent the development of conditions that really are going to impact into the quality of life of people living with obesity.
Bravo.
Yes, now we have to think about the whole treatment journey in obesity management. The first phase is induction of weight loss, and the second phase is maintenance. And the third phase is complication-focused care, as I mentioned. For example, a patient with obesity and type 2 diabetes may benefit from a therapy with strong glycemic and weight reduction. A patient with obesity and at risk of muscle D may need a therapy with strong effect on liver fat and inflammation. The third case is a patient with sarcopenic obesity may need careful nutritional support or resistant exercise while receiving pharmacotherapy such as amylin and others. So the future obesity care will be more phenotype-based.
I'm looking forward to that. It's right now we tend to have a one-size-fits-all approach, and it's not right. We need to improve our guidance. I'm really happy to be talking to you guys today because I think what we're seeing evidence emerge that is going to affect our guidelines. So we really have some astounding things that are happening very rapidly in the field.
I think my take-home message is that obesity management is now entering a new phase. So we should move from BMI-based short-term treatment to complicate-based long-term care, long-term maintenance care. The future will be about using the right therapy for the right people at the right time.
We do have now weapons to fight diabetes, but please stay tuned. More are to come.
That's right. Absolutely. We're so fortunate to be at an age where we have choices to help our patients. We have injectables, we have orals, we have small molecules, we have peptides. We have medications that produce robust weight loss, really rivaling bariatric surgery. We have medications that have special properties that can be targeted to special diseases. For example, MASH, liver disease. For example, cardiovascular diseases. We have medications that have indications for obstructive sleep apnea. So I think identifying the right medication for the right patient is where we're really going to be putting our efforts going forward.
Thank you, Drs. Del Prato, Lim, and Ryan. And many thanks to you, our listeners, for joining us. As a reminder to view the full program, Global Perspectives on Emerging Evidence in Obesity Management, What's New, What's Next, and What Matters for Primary Care, please click the link in the show notes. And be sure to check back regularly for more episodes on important multi-specialty topics.